think there's a lot of downstream impacts
Right.
of going beyond first line, right? Which is why when I present first line trials to people, there is a strong sense of commitment on my part, but really education that we need our best tools to set you up for the best long-term, not only survival, but the best quality of your life. And as a field, I feel very proud of the fact that most of my patients, looking back, that I can say that most people have had fairly good quality of lives until the very end.
Yeah.
But I want there to be more
the goal, right?
of
Which
that.
is the goal. Absolutely. Yeah. And that's so important because we absolutely, our goals in treating metastatic breast cancer, it's not only to help people live longer, but for sure to help them live better. And so the idea of this, being able to intervene before progression, I mean, do you feel like at least the data tells us from the patient-reported outcomes, the data really tells us that seemed to translate to patients, that they had, longer time to deterioration and a variety of important, endpoints. So maybe speak a bit about that and what your experience was with that in the study.
Right. So the study reported time to deterioration was around 23 months versus 6 months in the comparator arm. That's a hugely abysmal difference, right? And then when they looked at various markers and endpoints of global health status and quality of life, there were specific things that stood out to me. One was pain. Other was fatigue. We know that these two things are hugely and fundamentally life-changing for people.
Absolutely.
Right? If back to your point, if you don't live life well and good enough,
right,
what's it worth? I think about my 90-year-olds, right? Who are like, I don't want to live past 90 in certain aspects because life is harder then. I think we can take that a little bit into the space and patients with metastatic breast cancer. It's like, what's the point of living longer if while I live my life, things are more difficult?
Right.
The other endpoint of quality of life measurements was shortness of breath that they reported out was better, social functioning, even anxiety, emotional well-being. And also breast and arm symptoms were reportedly all better.
That really supports, what you were saying earlier, that the patients seem to really appreciate this idea of empowerment and being monitored very carefully and being able to do something before radiographic progression. I know when we first saw the SERENA-6 data, there was maybe some discussion, we all were in the course of trying to really let that sink in and let that process. There was this discussion about scanxiety, right? This idea that every time you're having scans, that creates anxiety. And if we're doing more frequent scans and or more frequent testing, in this case, blood testing, that maybe translates to increased anxiety. But I think, now that we've seen the patient-reported outcomes, it's really quite the opposite. Like patients seem to have less anxiety. Anxiety and sort of social functioning was one of the metrics from the patient-reported outcome. And so having them report, I think it was significantly like 50% less or something anxiety for the patients that were on the intervention arm as opposed to people that were on the control arm. I think it kind of contradicts that whole idea of more testing equals more anxiety.
Right.
Yeah.
I think maybe that's something that we could do better as a field, is sort of understanding more from our patients and our advocates about what truly matters to them. And I think that's one really great example.